Welcome to the Deep Dive, the place where we cut through the massive volume of information, stack up the essential facts, and hand you the synthesized knowledge you need to be clinically prepared.
Today we have a really big one. We're tackling the entire integumentary system unit. We're pulling together structures, functions, common disorders, wound care, and then the big one, burns.
That's right. And this is all coming from three huge chapters in Brunner and Sutter's Medical Surgical Nursing 15th edition.
A book that can definitely be intimidating.
For sure. So our mission today is really to be your ultimate shortcut. We're taking this sprawling and, let's be honest, often stressful textbook unit and turning it into a focused conversation you can actually remember.
We want to go beyond just definitions. We're focusing on the why and the how for your actual nursing practice.
Okay, so let's start with the big picture. What's the overarching clinical theme the book establishes for the skin?
The book is really clear on this. The skin isn't just a covering, it's the body's largest organ, and its integrity is absolutely foundational for survival.
It does so much more than just hold us together.
Exactly. It's about protection, sensation, temperature control, immune response, and it's also a mirror. It often reflects what's going on deeper inside systemic health issues, nutritional problems, you name it.
So that means the nursing responsibility is huge. You could be dealing with anything from simple dermatitis to a life-threatening burn.
And you need that same evidence-based rigor for both. So we're going to keep the language clear and really focus on the kind of high-stakes decisions you'll be making.
I think a good way to start is with that QSEN focus box that text provides on evidence-based practice, or EBP. It gives a really practical scenario.
Right. The 22-year-old woman with a family history of melanoma, she gets diagnosed with melanoma in situ on her shoulder.
Which means the cancer is just in that top layer of skin, the epidermis.
Correct. And her dermatologist recommends excising it with 2.5 centimeter margins.
Okay, so as the nurse, what's your EBP obligation in that moment?
It's twofold. First, you have to ask, what's the evidence supporting that specific margin size? Is 2.5 centimeters the standard based on the best research?
And what's the second part?
The second part is patient education. What are the absolute best evidence-based prevention strategies you need to teach this patient right now to reduce her future risk?
So EBP isn't just knowing a definition. It's about being able to connect the research, your own expertise, and what the patient needs and values.
Precisely. When she asks you, why so much, or is this really going to get it all, you need to be able to explain that the recommendation comes from solid evidence.
It's a great way to frame everything we're about to talk about. Know the fundamentals, but always be ready to back it up with the why. Okay, let's get into our first major segment. Structures, functions, and comprehensive assessment, pulling all the core knowledge from Chapter 55.
Let's start with the basic anatomy. It's helpful to think of the skin as a kind of three-story building.
So the roof would be the top layer, the epidermis.
Exactly. It's the outermost layer. Its main residents are cells called keratinocytes. They're constantly being made in the bottom layer of the epidermis and pushed up.
And they make keratin, which is that tough, waterproof protein.
Right, and that forms the very top layer, the stratum corneum. It's our primary protective barrier. And this whole process, this whole layer recycles itself every 3 to 4 weeks.
But there are other important cells in the epidermis too, right? The text points out a couple of others.
Yes, absolutely. You have the melanocytes, which produce melanin, the pigment that gives skin its color.
And an important point here is that everyone has about the same number of melanocytes.
That's a key concept. Skin color variation comes from the amount and type of melanin produced, not the number of cells.
Okay, and the other critical cell type, the immune cells.
Those are the Langerhans cells. Think of them as the immune system's sentinels or early warning system in the skin. They're a type of dendritic cell.
So what do they do?
When something foreign gets in, like an allergen from poison ivy, the Langerhans cells grab it, process it, and carry it to the nearest lymph node to show it to the T cells.
And that's what kicks off the allergic reaction.
Yes, that's the mechanism behind a delayed hypersensitivity reaction. It's a critical part of our adaptive immunity.
Okay, so that's the roof. Moving down to the middle floor, we have the dermis.
The dermis is the support structure. It's much thicker. It's made of dense connective tissue collagen, elastic fibers that give skin its strength and stretch.
And this is where all the stuff is, right? The blood vessels, nerves.
Exactly. It's vascularized, it's innervated, it's got the hair follicles, the sweat glands, all of that is housed in the dermis.
The book also talks about how the dermis and epidermis connect. It's not just a flat line.
No, it's a very complex junction. It has these undulations, these ridges called reet ridges, that kind of lock the two layers together like puzzle pieces.
Yeah,
This becomes a huge issue in aging skin when those ridges flatten out.
we'll get to that. Okay, finally, the foundation of the building, the subcutaneous tissue.
Or the hypodermis. This is mostly adipose tissue, fat and loose connective tissue. Its job is purely functional.
Insulation, cushioning.
Insulation, cushioning against trauma, and it allows the skin to move over the muscle and bone underneath. It's key for temperature regulation.
So if we put all those layers together, we get the skin's core functions. Protection is the obvious one.
Yeah, and the protection is layered. You have the physical barrier of keratin, but also a waterproofing barrier made of lipids in that stratum corneum. If that lipid barrier breaks down, you get massive water loss.
Then we have sensation from all the nerve endings and the immune response from the Langerhans cells.
And the one that sometimes surprises people, vitamin D synthesis.
Right, UV light hits the skin and starts the process.
It does, but the text is very, very clear on the evidence-based practice here. We do not recommend intentional sun exposure to get vitamin D.
Why not?
The risk of skin cancer is just too high. You need to get adequate vitamin D from your diet and from supplements. That is a critical piece of nursing education.
Let's talk about what happens as we age, the gerontologic considerations. Why does skin get so much more fragile?
It's because the changes are deeply structural, not just cosmetic. The dermis gets thinner, collagen degenerates, you produce less sebum, so the skin gets very dry.
And you mentioned that junction between the epidermis and dermis flattening out.
Yes, and that is a massive problem. The anchoring system is basically gone. This is why even a small amount of force can cause huge damage.
You mean like shearing force?
Exactly. If you slide an older patient up in bed instead of lifting them, that shearing force, where the skeleton moves but the skin stays put, can literally tear the epidermis right off the dermis. It's a direct cause of skin tears and pressure injuries.
And this affects more than just the skin's integrity, doesn't it? Body regulation, too.
Absolutely. When you lose that subcutaneous fat, you lose insulation. So older adults get cold very easily or overheat. Their thermoregulation is impaired.
And wound healing.
It's much slower. The blood supply to the skin is reduced, so any injury they do sustain takes much, much longer to heal, which just compounds the risk of infection.
Okay, let's pivot now to the hands-on skills. Nursing assessment priorities. And it all starts with a really detailed subjective history.
Meticulous is the word. You need specifics. Where did the first lesion appear? How fast did it spread? What did it feel like? Was it itchy, painful, tingling?
And you have to ask about family history and environment, too.
For sure. Sun sensitivity, any history of weird healing, and definitely any family history of skin cancers or other specific skin diseases.
Now, for the physical assessment, the book highlights a major challenge: assessing skin color changes across different skin tones.
This is so, so important. You can miss life-threatening problems if you're only looking for signs that appear on light skin. Let's take a couple of examples right from Table 55.1.
Let's start with pallor or paleness.
In a light-skinned person, they just look pale all over. But in a person with dark skin, you won't see that. You have to look at the mucous membranes inside the mouth, the conjunctivae. Pallor will look more like an ashen gray or maybe a dull, sort of yellow-brown color.
And what about cyanosis? That's even more critical to catch.
Extremely critical. In light skin, you see a dusky blue color. In dark skin, the skin might just look dark, dull, or grayish. The blueness is very hard to see, so again, you must check the nail beds, the oral mucosa, the conjunctivae. If you only look at the skin, you could miss severe hypoxia.
It sounds like it can be very subtle.
It is. The skill is about comparing and palpating for temperature changes and always, always checking those mucous membranes. Same with erythema or redness. In dark skin, inflammation might look more like a purple-gray color. You have to palpate for warmth or swelling.
Okay, let's quickly define a few other key color terms.
Sure. Ecchymosis is just a bruise bleeding into the tissue. Hyperpigmentation is an increase in melanin, and hypopigmentation is a loss of it. The classic example of hypopigmentation is vitiligo, where you see those distinct, milky white patches of skin.
Next, we need to learn the language of dermatology, how to describe lesions, vascularity, and configurations. Let's start with primary versus secondary lesions.
So primary lesions are the first thing to appear. They are the initial characteristic of the disease itself.
Like a freckle or a blister.
Right. A macule is a flat spot, like a freckle. A papule is a small, raised, solid bump, like a wart.
And how is that different from a plaque?
Size and shape. A plaque is also raised and solid, but it's larger, and it's often formed by a bunch of papules that have merged together. This is the classic lesion you see in psoriasis.
And a bulla?
A bulla is just a big blister, larger than half a centimeter. Think of a large burn blister.
Okay, so then what are secondary lesions?
Secondary lesions are what happens to the primary lesions over time, maybe from scratching or infection or just the healing process.
So an ulcer would be a secondary lesion.
Exactly. An ulcer is when there's actual loss of tissue down into the dermis. A fissure is a deep crack, like severely chapped lips. And lichenification, that's the term for skin that's become thick and leathery from chronic scratching.
And a keloid.
A keloid is an overgrowth of scar tissue. It's a type of secondary lesion that's much more common in people with darker skin.
The pattern of the lesions is also a huge clue for diagnosis.
A huge clue. You need to describe if they're linear, in a straight line, or annular, which is circular, like in ringworm.
And the one that is a dead giveaway for shingles.
That's zosteriform. It's a linear pattern, but it specifically follows the path of a single nerve. It's pathognomonic for herpes zoster.
Last thing in this section, turgor and vascular changes?
Turgor is just skin elasticity. We use it to check for dehydration, though it does decrease with age naturally. For vascular changes, you need to recognize petechiae.
Those are the tiny pinpoint red spots.
Right, and they don't blanch when you press on them. They can signal a serious clotting problem, so they need to be reported immediately. And you should also know what a spider angioma looks like, a central red spot with little vessels radiating out, often linked to liver disease.
Let's quickly wrap up assessment by looking at hair and nails, because they can tell us a lot about systemic health.
They really can. For hair, you're looking at texture and distribution. Really dry, brittle hair could be a sign of thyroid problems.
And what about unusual hair growth?
In women, if you see excessive male pattern hair growth, that's called hirsutism, it should prompt a workup for a hormonal issue like PCOS.
And what about hair loss?
Well, there's androgenic alopecia, which is just your typical genetic male or female pattern baldness. But then there's alopecia areata, which is different.
How so?
It's an autoimmune condition that causes these very distinct, well-defined patches of hair loss. The good news is it often goes back on its own.
Okay, turning to the nails. The book shows a diagram, figure 55-6, of the normal angle of the nail.
Yes, it should be about 160 degrees. If that angle flattens out to 180 degrees or more, and the nail bed feels kind of spongy, that's clubbing.
And clubbing is a big red flag.
A huge red flag for chronic hypoxia. You see it with severe lung disease, heart disease, things like that.
And what about lines or marks on the nail?
Look for bow lines. These are horizontal depressions across the nail. They basically mark a time when nail growth stopped or slowed down dramatically because of a severe illness or major trauma. You can even estimate when the illness happened by how far the line has grown out from the cuticle.
Okay, we've laid the foundation. Now let's get into Chapter 56, focusing on the management of dermatologic conditions and wound care. We can start with pharmacology.
Right, and with topical medications, the first decision is about the formulation. It really depends on how wet or dry the skin lesion is.
So you wouldn't use the same thing for an oozing rash and a dry, scaly patch?
Exactly not. For acute, weepy, inflamed skin, you might use cooling compresses. For subacute stages, you'd use things that are easy to spread, like lotions and creams.
But for the really chronic, dry, thickened skin, that lichenification we talked about.
For that, you need an ointment. Ointments are oil-based. They provide the best occlusion and softening power, which is what you need to penetrate that thick skin.
And the drug we see used most often in these topicals is the corticosteroid.
They are the workhorses. They're powerfully anti-inflammatory and they help with itching, but they come with significant risks, which makes nursing education critical.
And the key is absorption, right?
It's all about absorption. Anything that increases hydration of the skin, like putting an occlusive dressing over the medication, dramatically increases how much drug gets absorbed.
And that can lead to side effects. What do we need to teach patients to look for locally?
The big ones are skin atrophy, which is a severe thinning of the skin, striae, which are stretch marks, and telangiectasia is those little spider veins.
And the book gives a really important safety guideline about where not to use the high-potency ones.
This is a crucial point. High-potency steroids should be used for a limited time, maybe 4 weeks max, but they should be avoided completely on the face and in the intertriginous areas.
So armpits, groin, any skin folds.
Right. The skin is naturally thinner there, so you get way too much absorption, which can cause that local damage really quickly, and even systemic side effects. It's a very easy mistake to make.
All right, let's move on to wound dressings. The whole approach to this has changed, hasn't it? The key now is moisture.
It is. The evidence is overwhelming that wounds heal better in a moist environment. So modern dressings are designed to create and maintain that. It speeds up healing, reduces pain, and helps the body's own enzymes clean up the wound.
That's called autolytic debridement.
Autolytic debridement, exactly. Let's walk through the four main types from table 56 to 1.
Okay, first up, hydrogels.
Think of hydrogels as adding water. They're mostly water. You use them to rehydrate a dry wound like a radiation burn. They don't stick, so they always need a cover dressing.
Number 2, hydrocolloids.
These are very popular. They're adhesive, they absorb drainage, and they turn into a gel. The key teaching point here is about the smell.
What about it?
When you take a hydrocolloid off, there's often this foul-smelling, yellowish gunk on the wound. That is a normal chemical reaction of the dressing. It is not infection.
That is a great tip, so patients won't panic.
Right. And you can leave them on for several days, but a big contraindication. Never use them on an infected wound.
Okay, third, foam dressings.
These are simple. They're super absorbent polyurethane sheets. They're great for wounds with moderate to heavy drainage, and they provide excellent cushioning over bony areas.
And finally, calcium alginates.
These are derived from seaweed, from kelp. They are incredibly absorbent. They form a soft gel as they soak up drainage, which makes them perfect for packing deep wounds or sinus tracts. They're one of the best choices for debriding a wound with a lot of necrotic tissue and exudate.
Now, for a topic that is just central to med-surg nursing, pressure injuries, and we have to use that term, right? Not ulcers.
That's the correct terminology now, yes.
Yeah.
And prevention is everything. You have to know the risk factors: immobility, moisture, friction, shear, poor nutrition.
And we use a standardized tool to assess that risk.
The Braden scale. It gives you a score based on sensory perception, mobility, nutrition, and so on. The lower the score, the higher the risk, and the more aggressive your prevention plan needs to be.
Let's talk about the pathophysiology. It's not just about pressure.
No, it's not. The core damage is from unrelieved pressure cutting off blood flow. But the mechanical forces are huge contributors. You have friction, which is just skin rubbing on sheets.
And then you have shear.
And shear is the silent killer. Shear is when the layers of tissue slide over each other. Imagine a patient in a semi-Fowler's position sliding down. Their bones move down, but their skin gets stuck to the sheet.
And that stretches and tears the deep blood vessels.
Exactly. It causes damage deep down at the bone-muscle interface long before you see anything on the surface. It's what leads to those awful deep tissue injuries.
Okay, we have to walk through the staging system from chart 56-2. Let's describe each stage.
All right, stage 1. The skin is still intact, but you have an area of non-blanchable erythema, redness that doesn't go away when you press it.
The first sign of trouble.
The very first sign. Stage 2 is partial thickness skin loss. You can see the dermis. The wound bed is pink or red and moist. It might look like a ruptured blister, but you do not see any fat tissue.
Okay, so when you see fat, you're at least at stage 3.
That's the rule. Stage 3 is full thickness skin loss. Adipose tissue is visible. You might see some granulation tissue, maybe some undermining or tunneling, but you do not see bone, muscle, or tendon.
And when you do see those deeper structures,
You're at stage 4. Full thickness skin and tissue loss. You can see or directly feel fascia, muscle, tendon, ligament, or bone. These are devastating.
then there are the two tricky categories where you can't assign a stage.
Right. First is unstageable. This is when the wound bed is covered by slough, that yellow stringy stuff, or eschar, the hard black necrotic tissue. You can't see how deep it is, so you can't stage it.
And there's a really important safety alert about eschar on the heels.
A critical one. If you have stable eschar, meaning it's dry, intact, and not showing signs of infection on the heel or an ischemic limb, you generally should not remove it. It's acting as the body's own biological cover. Removing it can open the door to a terrible infection in an area that already has poor circulation.
And the final category, the one that starts deep.
The deep tissue pressure injury, or DTPU. This looks like a persistent deep red, maroon, or purple bruise over a pressure area. The skin might be intact. This is that deep shear injury we talked about, and it can become a full-blown stage 3 or 4 ulcer almost overnight. It's an emergency.
And for those deeper stages, you have to get the dead tissue out.
You have to. That's debridement. Necrotic tissue is a breeding ground for bacteria, and it physically stops the wound from healing. It can be done in different ways, but it's almost always painful, so pre-medicating your patient is a key nursing role.
All right, let's shift gears to infectious dermatoses, starting with the bacterial ones.
The classic superficial one is impetigo. The key thing to remember is the visual progression. It starts as little red spots, they become vesicles, they rupture, and then they form these very characteristic honey yellow crusts.
And treatment involves getting those crusts off.
Yes, you have to gently wash them off so the topical antibiotic, like mupirocin, can actually get to the infection underneath.
Okay, what about the deeper infections? Furuncles and carbuncles.
A furuncle is a boil, an infection of one hair follicle. A carbuncle is much worse. It's when the infection spreads to involve several follicles, creating a big, deep abscess. They often need to be incised and drained.
And there's a huge safety alert about boils on the face.
This is a life or death piece of knowledge. You must never squeeze a boil on the face, especially in that triangle area around the nose and upper lip.
Why is that so dangerous?
Because the veins in that area drain directly back into the brain. If you squeeze it, you can push that staph infection right into the cranial venous sinuses and cause a brain abscess or a cavernous sinus thrombosis. It's a true medical emergency.
Wow. Okay, moving on to viral. Let's talk herpes zoster, or shingles.
So this is the reactivation of the chickenpox virus, VZV, which has been lying dormant in the sensory nerves.
And it comes out along a dermatome, that nerve path.
Exactly. And it has 3 phases. The pre-eruptive phase, where you just have pain or tingling along that nerve. Then the acute eruptive phase, when the classic unilateral rash appears with severe pain. And the worst complication is the 3rd phase, postherpetic neuralgia.
Debilitating pain that just lingers for months or years.
Yes. So management is about starting antivirals as early as possible, ideally within 72 hours of the rash, and aggressively managing the pain.
And prevention is key.
Vaccination. The recombinant zoster vaccine, Shingrix, is highly effective and recommended for adults 50 and over.
The book also mentioned a strange skin finding from the pandemic. COVID toes.
Yeah, this was fascinating. These pernio-like lesions, they look like chilblains on the toes and fingers. They weren't from cold exposure. They were often the only sign of a COVID-19 infection, especially in younger people. So the takeaway is, if you see that, you should test for SARS-CoV-2.
And just to round out infections, a quick mention of fungal and parasitic.
Sure. Fungal is your tinea, or ringworm, named for the body part it affects. For parasites, the big 2 are scabies, the itch mite that burrows under the skin and causes intense itching, especially at night, and petechiae, or lice. With body lice, remember they live in the seams of clothing, not on the body, so treating the clothing is the priority.
All right, let's move into our third segment on the chronic non-infectious disorders and skin cancer. Let's start with psoriasis.
Psoriasis is a chronic inflammatory autoimmune disease. What's happening is that the immune system is sending faulty signals that tell the skin cells to grow way too fast.
So instead of the normal month-long cycle.
It happens in just a few days, so you get this massive pileup of immature skin cells on the surface, which creates those classic thick red plaques with the silvery scales.
And since there's no cure, what are the management goals?
It's all about control. Slowing down that cell turnover, we use topical corticosteroids, sometimes with occlusive dressings. There's also a nonsteroidal called calcipotriene, which is a vitamin D derivative that helps.
And for more severe cases?
We can use phototherapy, which is controlled UV light. And then there are systemic drugs. The first-line one is often methotrexate, which is a cytotoxic agent that slows down cell division. But it's a serious drug that requires close monitoring for liver and kidney toxicity.
Okay, what about contact dermatitis?
This is just an inflammatory reaction to something that touched the skin. The book points out the huge rise in this among healthcare workers during the pandemic from constantly wearing PPE and using hand sanitizer. The key is to identify and remove the irritant.
Now for the really scary ones. Toxic epidermal necrolysis, TEN, and Stevens-Johnson syndrome, SJS.
These are true dermatologic emergencies. They are a spectrum of a severe, life-threatening reaction, usually to a medication.
And clinically, what does it look like?
It starts with widespread redness and blistering, but then the epidermis starts to literally detach and slough off in sheets.
The book says it's like a massive, full-body, partial thickness burn.
And that's exactly how you have to treat it. The mortality rate for 10 can be as high as 35%. You lose your skin barrier, so you have massive fluid loss, you can't regulate your temperature, and you're wide open to sepsis. These patients need to be in a burn center or an ICU.
Let's turn to skin tumors and cancers. This is the most common cancer in the U.S., so prevention is a huge nursing role.
And the #1 cause is UV radiation from the sun and tanning beds. It's almost entirely preventable.
We'll start with the non-melanoma cancers, BCC and SCC.
Basal cell carcinoma, or BCC, is the most common by far. It's usually a slow-growing, waxy-looking nodule with these classic rolled, pearly borders. It almost never metastasizes, but it can be very locally destructive if you ignore it.
And squamous cell carcinoma, SCC.
SCC is a bit more aggressive. It often starts from a precancerous lesion called an actinic keratosis, which is a rough, scaly patch. SCC itself is a rough, thickened, scaly tumor. It does have the potential to metastasize, so it needs to be treated.
And that brings us to the deadliest form, melanoma.
It's only about 1% of skin cancers, but it causes the most deaths. Early detection is everything, and that's where the ABCDEs of moles come in. This is a core nursing assessment skill.
Let's review them quickly. What are we looking for?
A is for asymmetry. One half doesn't match the other.
B is for border.
The border is irregular, notched, or blurred.
C is for color.
Color variation. Multiple shades of brown, black, even red or blue in the same lesion.
D is for diameter.
Larger than 6 millimeters, about the size of a pencil eraser.
And the most important one, E is for evolving.
Any change in size, shape, color, or if it starts to itch or bleed, any change needs to be checked out immediately.
And our role in prevention, besides teaching the ABCDEs, is sun safety.
Sun safety for everyone. Avoid the sun between 10 a.m. and 4 p.m., wear protective clothing, use a broad spectrum sunscreen of at least SPF 15, and reapply it every 2 hours. It doesn't matter what your skin tone is.
For surgical treatment, the book highlights Mohs micrographic surgery. Why is that considered the gold standard?
Because it has the highest cure rate while sparing the most healthy
Yeah.
tissue. The surgeon removes the tumor one thin layer at a time and looks at it under a microscope right there. They keep taking layers until they hit a layer that is completely cancer-free. It's incredibly precise.
Okay, we've reached the capstone of the unit, Chapter 57, Burn Injuries. This is where a skin injury becomes a full-blown systemic catastrophe.
It really is. A burn is a local injury with profound system-wide consequences. The tissue destruction triggers this massive, overwhelming inflammatory response.
Let's really break down the cardiovascular and fluid changes that happen right away. This is burn shock.
Okay, so within minutes of a major burn, your cardiac output drops. At the same time, all those inflammatory mediators that are released make your capillaries incredibly leaky.
So plasma starts pouring out of the blood vessels.
Exactly. Massive amounts of plasma, protein, and electrolytes leak out of the intravascular space and into the surrounding tissue. This is the fluid shift.
So the patient gets incredibly swollen, or edematous, but their circulating blood volume is dangerously low.
That is burn shock in a nutshell. And this leak is fastest in the first 6 to 8 hours after the injury. That's the window where you can fall behind on fluid resuscitation very, very quickly.
And what happens to electrolytes, like potassium?
Initially, when all those cells are destroyed, potassium floods out of them, so you get a period of hyperkalemia, which puts the patient at risk for cardiac arrhythmias.
What's the biggest threat to survival besides the burn size itself?
Inhalation injury. It's a major cause of death. If you see singed nasal hairs, burns on the face, if their voice is hoarse, or if they have soot in their sputum, you have to assume they have an inhalation injury.
And what is the most ominous late sign of that?
Stridor. That high-pitched, harsh sound on inspiration. It means their upper airway is swelling shut. It is a sign that they need to be intubated immediately before you lose the airway completely.
Okay, let's walk the patient through that first critical phase, the emergent or resuscitative phase.
Your priorities are the ABCs. Stop the burning process, get an airway, give them 100% humidified oxygen, especially if you suspect carbon monoxide poisoning.
And get IV access. But there's a key point about timing the fluids, right?
The clock starts at the moment of injury, not when they get to the hospital. You have to calculate how much fluid they should have received from the time they were burned and catch up. That's why you need large bore IVs.
What other invasive lines are essential for a major burn?
2 things. 1, an indwelling urinary catheter. Urine output is your best guide to whether your fluid resuscitation is working. You titrate your IV fluids based on their urine output.
And the second one?
For any burn over 20 to 25% of their body, a nasogastric tube. A major burn causes a paralytic ileus. The gut just stops working. The NG tube decompresses the stomach and prevents them from vomiting and aspirating.
Once the patient is stabilized, they move into the acute or intermediate phase. The focus shifts now, right?
Completely. Now it's all about wound care and preventing complications, especially infection. Sepsis is the leading cause of death in this phase.
So infection control is paramount.
Rigorous. We use barrier precautions, environmental cleaning, and topical antimicrobial creams. We try to avoid systemic antibiotics unless there's a documented infection to prevent creating resistant bacteria.
And the wound care itself centers on debridement.
Right, getting rid of the dead, non-viable tissue. This can be done mechanically at the bedside. But I have to make a point here about wet to dry dressings.
What about them?
They are strongly discouraged now in modern wound care. They are non-selective. When you rip that dry gauze off, you're pulling off healthy new granulation tissue along with the dead stuff, which just sets healing back.
So for big burns, the best method is surgical.
Yes, surgical debridement, where they take the patient to the OR, excise the dead tissue, and immediately cover the wound with a skin graft. It drastically reduces infection risk.
And when a patient gets a graft, what's the nursing priority?
Protect that graft. It has to be kept completely immobile for several days so that new blood vessels can grow into it. Any shearing force can disrupt it.
And what about the donor site?
The donor site is a fresh, partial thickness wound, and it is often more painful than the burn itself. It needs its own dedicated pain management plan.
Let's talk more about that pain. It's incredibly complex in burn patients.
It is. You have to manage 3 different types of pain at once. You have the background pain, which is the constant, dull ache that needs around-the-clock medication.
Then you have breakthrough pain.
Those are the sudden, severe spikes of pain. You need fast-acting rescue doses for that.
And the third, and maybe the worst, is procedural pain.
Yes, the intense pain that comes with dressing changes or physical therapy. This requires aggressive premedication with strong IV analgesics and often anxiolytics well before the procedure even starts.
And we also have to manage their metabolism.
Yes, burn patients go into this profound hypermetabolic state. Their bodies are burning through calories at an incredible rate. You have to start nutritional support, usually with a feeding tube, almost immediately to prevent them from breaking down all their muscle mass.
Okay, the final stage of care is the rehabilitation phase. This starts on day 1, but it can last for years.
Yes, the focus here is on maximizing function and preventing the long-term complications, which are mainly contractures and hypertrophic scarring.
How do we manage this scarring?
The main strategy is compression therapy. Patients are fitted for these custom elastic pressure garments that they have to wear for 23 hours a day.
For how long?
It can be for a year, sometimes longer. The constant pressure helps remodel the collagen and flatten the scars.
And preventing contractures.
That's all about range of motion. Early, consistent, and often painful physical and occupational therapy to keep the joints moving and prevent the new skin from tightening up and limiting mobility.
This sounds like an incredibly difficult recovery, not just physically, but emotionally.
The psychosocial needs are immense. You're dealing with PTSD, depression, anxiety, and profound body image issues. The nurse's role is to provide constant support, anticipate these needs, and coordinate the right mental health and rehab services. Recovery is a marathon, not a sprint.
We have covered a huge amount of ground here, from the microscopic level of the cell all the way to the systemic management of catastrophic trauma.
We have. And if I had to boil it down, I'd say the nursing role here is threefold. First, it's mastery of assessment. Being able to see those subtle color changes, describe a lesion accurately, stage a pressure injury correctly.
Second would be the application of EBP.
Right. Knowing why you don't use wet to dry dressings, understanding the risks of topical steroids, and teaching sun safety to every single patient.
And the third piece.
Holistic care. Managing that intense procedural pain, understanding the systemic nature of a burn, and providing that long-term psychological support. The skin really is where it all comes together.
It's the canvas where internal health and external threats meet, and the nurse is right there at that interface.
And that actually brings me to a final provocative thought for you to take with you. We've established how critical evidence-based care is, especially for something like melanoma.
Right.
So what do you do when you have a patient who maybe out of fear or desperation is using a non-evidence-based treatment, like a black salve or some herbal paste they found online, maybe even funded through a crowdfunding site? How do you, as the nurse, balance respecting their autonomy and their values with your absolute duty to advocate for science-based, life-saving care?
That challenge balancing trust and hope and hard scientific evidence, that might be the most complex nursing skill there is. Thank you for diving deep with us today. We hope you take this knowledge and use it with confidence in your studies and in your practice.